Welcome to the Overview of Study Designs lecture. This lecture is intended to introduce you to the different types of study designs and help decipher which study designs can be used to answer which research questions, as well as being able to understand the nuances for each study design and how that may impact your interpretation of the results. There are 4 learning objectives for this lecture, which can be found on this slide, and 2 required readings, one an article from The Lancet and the other is a chapter in your textbook. So before we begin to delve into the different types of study designs, I want everybody to be familiar with some common epidemiology terms. Incidence, prevalence particularly are important to differentiate. So incidence is the measure of new cases of the disease, while prevalence is all cases. So we can measure incidence as the number of new cases of disease that develop in a specific population over a specific period of time. Prevalence can be measured by determining the proportion of the population that has the disease. In the bathtub, new cases, i.e. incidents, are dripping in. The total cases is the water in the tub consisting of the new cases dripping in and the already existing cases. So prevalence, the total cases, can decrease if people recover from their disease or die from their disease. So why do we bother to study populations? There's several reasons why we want to study populations. It's to help us identify patterns and trends in the occurrence of different diseases. We want to study populations to understand how our treatments can be effective or have efficacy. We evaluate traditionally in many drug trials, we evaluate in randomized controlled trials the efficacy, potentially safety of these measures. We also have study designs which can help us evaluate the effectiveness, the tolerability of preventive and therapeutic measures. And it's important to differentiate between efficacy and effectiveness. So efficacy is traditionally the results in a controlled situation. So we think of that as a randomized controlled trial, whereas effectiveness are the results in a more typical situation, more real-world scenario. And there's different study designs which lend the ability to study these different measures in different patient populations. And lastly, another large reason why we study populations is we need evidence to determine public policy and regulatory decisions, as well as for making decisions about formularies and covering drugs and providing access to drugs for patients through insurance and other means. So for this overview of study design lecture, we're going to really concentrate on the analytical study design. So we can see descriptive in white on the left-hand side, qualitative case reports as an example. We're going to focus on analytical and talk about 2 different types of analytical study designs, experimental and observational. And this purpose today is really to introduce you to these different types of study designs and help to increase some familiarity, because you will be having individual lectures on experimental and on observational study designs, as well as appraising the evidence that you get from those types of study designs. So I like to think about experimental studies is when the investigator wants to learn about a prevention or treatment of disease. They offer a higher degree of validity than observational studies, as observational studies can be limited by uncontrolled bias and confounding. But there's also challenges with conducting experimental studies, such as non-adherence. What if patients in your clinical trial don't take the medication as directed? Experimental studies need to maintain high follow-up rates. We need to know what happened to the patients that are randomized to each of the treatment arms. We need to know about the concerns related to managing the trial and getting the data on those patients. Also, experimental studies may be higher cost, and there may be reluctance for physicians or patients to participate. And there's also other ethical issues which we'll talk about in another lecture later on down the road. Observational studies, on the other hand, can be used to look at a wider range of exposure, so including prevention, treatment, causes of disease. They can help explain incidence, although randomized controlled trials, the placebo arm, may explain incidence as well. But observational studies can also help us uncover determinants of disease progression and estimate our needs for health care and estimate what resources we should be putting toward certain patient populations. The biggest challenge with observational studies, as we'll see when we talk about the individual designs, is the investigator's inability to have complete control over extraneous factors. So the first type we're going to talk about is experimental studies. And I like to think about experimental studies as intervening. So we are, unlike observational, we're observing. Experimental is when we're intervening. We're randomizing patients to a treatment versus a placebo, or a treatment versus another treatment. And under the experimental treatment banner, we're going to talk mainly about randomized controlled trials, and we'll also mention the pragmatic clinical trials, a type of experimental study which gives us different evidence because they're designed slightly differently than traditional randomized controlled trials. So common features for randomized controlled trials, or RCTs, is randomization, random allocation of the intervention and the comparator to the participants. And I want to make sure we're clear here to differentiate this from random selection, where you take a random 10% of the population, which may be done in a random selection may be done in observational studies. Randomization is when you have your sample of participants and you randomize them to an intervention. A random selection is where you're taking a random sample of the participants. So important to differentiate between those two. Random allocation or randomization, it's to ensure that there's no systematic differences between the intervention groups in the factors that we know about, but also importantly in the factors that we don't know about. And that is a big challenge when we have other study designs, including observational study designs and non-randomized controlled trials, where because there may be unknown factors that you cannot account for, it is very difficult to establish cause and effect. So randomized controlled trials give you the best possibility with their design to establish a cause-effect relationship. So since they're the best, evidence to determine a cause-effect relationship, why don't we use them all the time? So I think we mentioned some of this before, but often randomized controlled trials are costly. They're time-consuming. There's difficulties recruiting patients. There's sometimes hesitation on the willingness of practitioners or patients to experiment or take risks. So these can all make observational studies easier to conduct than randomized controlled trial. The other aspect I want to mention with RCTs is the measures of association. So we learned about those in our deciphering health statistics, and relative risk and odds ratios are two measures of association we can use with randomized controlled trials. So here's an example of a simple flow diagram of a randomized controlled trial. This is a parallel group design, in other words, where the arms, the intervention and control, are happening at the same time. And followed over the same period of time, whereas there could be crossover where different groups get exposed to the treatment and the intervention and the control. So this is an example of a parallel group design. We can see that when you have their sample, there's inclusion and exclusion criteria, and if patients meet those, then they're randomized to receive the intervention, the allocation, or the control group, and then we follow them over time to measure the outcome. So an example of an experimental design is ALLHAT, the antihypertensive and lipid lowering to prevent heart attack trial. And we can see here high-risk hypertensive patients, once they met inclusion and exclusion criteria, were consented and then randomized to one of 4 antihypertensive agents: amlodipine, chlorthalidone, doxazosin, or lisinopril. And then interestingly, this had another or a second randomized arm where if those patients were eligible for lipid lowering and again consented, met inclusion exclusion criteria, they were then randomized to pravastatin or usual care. And this study was a longitudinal study over 8 years, and an average of 6 years. Participants had an average of 6 years of data. And the purpose of this study for the antihypertensive part was to determine which of these therapies was the optimal initial choice for blood pressure lowering. So when we look at the study design, patients had to meet inclusion and exclusion criteria, and you can see a whole host of criteria listed here. Now, part of the challenge we talked about with randomized controlled trials is they provide the best evidence for cause and effect, but they may suffer from challenges with generalizability. In other words, if your inclusion and exclusion criteria are so strict or narrow that you exclude participants that we would likely want to make decisions about blood pressure therapy in the real world, it decreases your ability to generalize the results from your study, your randomized controlled trial, to the general population. So we can look at several of these inclusion and exclusion criteria and determine whether we feel that that limits participation. So for example, in 2F, if you knew that there was a requirement for more than 2 antihypertensive drugs to achieve satisfactory blood pressure control, that might, in a sense, suggest that it was a less severe population, although that we know 75% of individuals will require at least 2 antihypertensive. So the majority require 2. The question is how many require 3, and when we look at this criterion, how does that affect our ability to generalize the results from this to the larger population at hand? And again, you can look at the other criteria and see how common those are in patients that would present with hypertension for initial therapy, and how the results from this study might impact your ability to make decisions for the population at hand or for patients that you're seeing in a clinical setting. So the challenges that we are very familiar with from randomized control that limit generalizability can be partly addressed by a somewhat new type of study design: pragmatic clinical trials. So this slide really differentiates the differences between a traditional randomized controlled trial and a pragmatic clinical trial. So traditional RCTs test hypotheses under ideal conditions. So we talked about that. There's oftentimes strict inclusion and exclusion criteria. Participants, because of that, are a very homogeneous group. There's measures that we collect, and they may not be typical of what we would collect in routine care. And the difference here is that a pragmatic clinical trial tries to mimic more conditions that are more real world. And so the benefits of a pragmatic clinical trial is that maybe greater generalizability of the data. And typically when they look at treatments, we're often comparing 2 or more treatments using flexible protocols and local customization. So whereas a traditional RCT might want to test drug A, for example, chlorthalidone versus placebo, a pragmatic clinical trial would maybe want to test chlorthalidone versus lisinopril. And so you can see here the differences between the pragmatic clinical trial and the randomized controlled trial, and also to think about ALLHAT. You know, some folks feel it maybe was more like a pragmatic clinical trial than actually a traditional RCT. Another example of a pragmatic clinical trial is the adaptable aspirin study. And in this infographic, you can see here that what we're trying to do is compare 2 dosage forms of aspirin, 2 doses of aspirin, an 81 milligram versus a 325. They're going to evaluate 20,000 patients across the United States, and they want patients with heart disease. So what we know is that, recommendations are, if patient has heart disease, they've had a heart attack, they've had a stroke, they have some type of atherosclerotic cardiovascular disease, we should use aspirin. The reality in practice is that we do not know which dose of aspirin gives us the best outcomes. So in this adaptable study design, this is kind of a schematic for how they enrolled patients and randomized them to aspirin therapy, the different doses. So what they were looking for is patients with known atherosclerotic cardiovascular disease, ASCVD, plus at least one enrichment factor. And I know the enrichment factors are not listed on here, although the link at the bottom will take you to those. But it could be someone who had 65 years and older, or somebody who was smoking. And these enrichment factors were really characteristics that we know increases the risk for the individual to have a major cardiovascular event. So we want patients with existing heart disease and at higher risk to have a cardiovascular event. And what we did then through the adaptable study design is to, once they meet inclusion and exclusion criteria, they get randomized to aspirin 81 milligrams or 325, and then they're followed up. And at the bottom of this slide, in the bottom center, you can see what are we looking for, the primary endpoints. So they looked at the composite of all-cause mortality, hospitalization for MI, or hospitalization for stroke. So one measure that had all three of those together. It's called a composite endpoint. But not only looking at efficacy, but also looking at safety. And here they were looking at a hospitalization for major bleeding. Because the challenge with not only determining the correct dose, we know that there are benefits for aspirin therapy in terms of cardiovascular risk reduction, but we also know there are risks or harms, such as bleeding from aspirin. So we want to understand where the benefit outweighs the risk. And this pragmatic clinical trial is hopefully helping us to address that, and will affect, depending on the results, may affect practice. So we're going to take a break here before we move to section 2, but just a quick summary. We've talked about the different types of study designs: experimental and observational. We focused on experimental, and in part 2 we'll talk about observational. But really experimental is where we intervene. We have the best opportunity in those study designs to determine a cause-effect relationship, but we also understand that there are challenges in conducting those studies, as well as the generalizability of the results to larger patient populations. So part 2 of overview of study designs, we're going to talk about observational studies, the other type of analytical studies. And there are several study types. The cohort study, case control, cross-sectional, ecologic, and case series. And we're going to talk about these different studies and hopefully give you some tips to help enable you to differentiate among them easily. So the first type of observational study design is the cohort study. And cohort studies, just like randomized controlled trials and also case control studies, we have the exposure preceding the outcome. Very important component in the longitudinality of studies. So cohort studies, we have an exposure preceding an outcome. And there are two types of cohort studies, and actually there's more than that, but we're going to focus kind of on two for the purposes of this course. And the two that we're going to talk about are the prospective and the retrospective cohort studies. Some common characteristics of cohort studies is that we select the participants based on the exposure. So we have a group of people, and some are exposed, some are unexposed. So if we were looking at people who were smoking, we would have exposure to cigarette smoke and non-smokers. Those would be our exposure. They must be free at the selection of when we've decided they have the exposure or not. They must be free of the disease. And this is because we're looking at incidence, right? We want to calculate the disease rate or the risk, the incidence, new cases of the disease. So if somebody already has the disease, they cannot be included in a cohort study. Similarly, for the randomized controlled trial, in the placebo arm, you can also calculate incidence of the disease. So I think things to think about, both study designs can give you new cases of the disease. The two measures that we use, the two measures of association that we use, again, similar to experimental studies, are the relative risk and the odds ratio. And that allows us to compare exposure groups. In the randomized controlled trial, we're comparing the intervention to the control, or the non-intervention. Here we're comparing the exposed group to the non-exposed group. So we're going to differentiate between two types of cohort studies: prospective cohort studies and retrospective cohort studies. And you can see by this figure the exposure present or absent is determined when the investigator starts their investigation. So here at the time of the investigation, exposure is known, it's either present or absent, and then patients are followed forward over time to determine the outcome. Outcome is not known in a prospective cohort when the researcher gets involved in the research study. So this differs from retrospective cohort studies, where when the researcher gets involved, the outcome and the exposure may already have happened. They may already have occurred because we're looking back in time, but we're still following patients. We're still following the group of exposed and unexposed forward in time to find out what outcome they had. But when the investigator comes in, the exposure and the outcome has already happened, unlike prospective. So for example, let's say patients started to take vitamins in the year 2000, and in 2005 they had an outcome of, heart disease or no heart disease. In a prospective, the investigator might have started at 2002 and found people who were taking vitamins, the exposed and the unexposed group, and then followed them forward to 2005 to find out the outcome. In the retrospective, the investigator might start in 2008. So the data from 2000 and the data from the outcome at 2005 would have already happened. It's just the investigators trying to find that. So I think to kind of help put cohort studies in perspective, is a common or a famous prospective cohort study is the Framingham Heart Study of 1948, and I've got the web address on there, and I encourage you to look at Framingham. This study really identified risk factors for heart disease, and it changed the way we thought about blood pressure and cholesterol, and it really provided new insights into the way not only we assessed the risk of an individual, but also how we evaluated the treatments to lower the risk of the individual. And this table is from a publication, I believe, from 1954. It was in the 50s, but it looked at the composition of folks included in this cohort for Framingham. And if you look at the first column, they took a random sample, and again, we're going to differentiate. This is not randomized people, right? Because they're not intervening, but there's a random sample of people they examined, and they got back 4,469 responded. So of the random sample they wanted, they didn't get everybody because not everybody responded. And then there was 4,393 who were free of coronary heart disease at the outset. So if our outcome is to find out new cases, incidents of coronary heart disease, we can't have people who have the disease at baseline. Again, a key principle of cohort studies, they have to be free of disease. They also had another group that volunteered. They weren't in the random sample, but they volunteered and they were free of coronary heart disease. So that made their total cohort that was free of coronary heart disease 5,127. And you can see they break down the difference between men and women that were included in the study cohort. And while Framingham has provided a lot of valuable information, one of the key mentions is there's a Framingham risk score that calculates your risk of getting a heart attack in the next 10 years. And that has been used to help determine, again, somebody's risk of having a problem and then the benefit of treatment to help lower or reduce that risk. So the next type of observational study is the case control study. And again, the main difference here to the cohort is that we start with the disease and the non-diseased population and then go back in time to determine exposure. So we still have the exposure preceding the outcome, but again, the way that we design the study is different because we don't start with the exposed and unexposed, we start with the diseased and non-diseased population and look back in time. So some common observations for case control studies, again, they may be very useful if you have a rare outcome or disease. So let's say you have a disease that happens in less than 1% of the population. You would have to study a lot of participants and follow them in a cohort prospectively for a period of time to try to identify the outcome because the outcome is rare. So here, if we start by having participants that have the disease and then get people that do not have disease, right? The cases are the ones with the disease, match them to controls that don't have the disease, then we can allow a comparison there because we've already identified the people that have the very rare disease or outcome. And the measure of observation used for case control studies is the odds ratio only. It's the only measure of association that we can use, unlike relative risk that we can also, relative risk we can use for randomized controlled trials or cohort studies. But odds ratio is the measure we use for case control studies. So let's look at a schematic. So again, when the researcher starts the research, both the exposure and the outcome have already happened in the past. But the difference here is that we start with the people that have the outcome. We identify the groups by the outcome or lack of outcome. So they have lung cancer, they don't have lung cancer. They have heart disease, they don't have heart disease. And we look back in time to determine whether they were exposed or unexposed in those two groups. So again, cohort starts with the exposure, case control starts with the outcome. But all cohort and case control do follow a temporal pattern of exposure preceding outcome. So here's an example of some case control work that was done that really helped us understand the association between smoking and lung cancer. So what they did is start with cases of lung cancer and looked back to look at their exposure for environmental tobacco smoke. Could be first-hand smoke, second-hand smoke, but that was helpful to help us understand that there was an association between smoking and lung cancer. And again, that would not be something that you would, that research question would not be something that you would study in a randomized controlled trial. You wouldn't randomize patients to smoking or non-smoking. So the case control study in this situation works very well. Another type of observational study is a cross-sectional study. And if you think about the word cross-section, it helps you because you're kind of looking at the data at a point in time. And the big difference here is that it's difficult to be confident that the exposure preceded the outcome because you're looking at patients at this, at one point in time. So for example, if I'm surveying you and I'm asking you if you have asthma and if you have a pet, did you get asthma before you had the pet? Did you have the pet before you got asthma? I don't necessarily know that. Now, certainly the way you can ask questions may help determine that temporality, but cross-sectional studies in general are more difficult than the other study designs to be confident with the exposure preceding the outcome. So when we think of cross-sectional, so we talked about cohort being incidents, right? Because we're following people exposed and looking for new cases, incidents. Cross-sectional really gives me prevalence. So if I ask 100 people in the room if you have asthma, that gives me the prevalence of asthma in that group that I asked. It's helpful to think of kind of cross-sectional as a snapshot in time. And we talked about it's difficult to determine whether the exposure actually preceded the outcome, although there's questions or ways to get the data that might help do that. And then lastly, the measure of association for cross-sectional is the same as that for case control. It's the odds ratio is the measure that we're using. So here's a nice graph of a cross-sectional study, the BRFSS, BRFSS, Behavioral Risk Factor Surveillance System. This is a nationwide study that the states administer and can sometimes ask their own questions. So there's a national set of questions, but also state, the ability the state has to ask specific questions, maybe relative to the state and the issues of health that are happening. So what happened during this survey is they asked participants what their weight was, and actually they calculated as a BMI, which is a measure of weight to height. And there's traditional categories of the BMI as healthy, 18.5 to 24.9, overweight, which goes 25 to 29.9, and then obese, which is 30 and above. But what they did was cross-tabulate. So they asked people, the same people that they asked their height and weight and got a BMI, they also asked them about whether they had been told that they had pre-diabetes. And they cross-tabbed this by age, right? So in age group 45 to 54, they found out what percentage of people who had a healthy weight had been told they had pre-diabetes. So you can see here the raw numbers as you go within each age group. As you go from healthy weight to obese, there is a higher percentage of patients with prediabetes that have been told. The challenge with this data is that you don't know, did the prediabetes come first and then they gained weight, or did they gain weight and then get the diabetes? So again, the challenge with a cross-sectional study is we don't know which one came first. And so it's oftentimes difficult to, we might say these two are related, but we don't have the ability of a temporality, and certainly we are unable to look at a cause and effect as we would in a randomized controlled trial. But again, we wouldn't randomize patients to gaining a lot of weight and following them over time versus not gaining weight over time. It just wouldn't be an ethical thing to do. Another type of observational study is the ecologic study, and I think these, in my opinion, are the easiest to kind of decipher. And the reason is because we're looking at data from groups. We're not looking at individual data. So if you just think of your unit of measure as a group, it could be a country, it could be a state, it could be a continent, it could be geographic areas. That is helpful to kind of differentiate ecologic from all of the other study designs. So here's a nice example of an ecologic study, and what this shows you is by country, total dietary fat intake. You can see it's grams per day. So as the dots go from the left to the right, there's a higher total dietary fat intake. So that's not individuals. They didn't get individual patients in here. They got data from the country, total dietary fat intake from the country. And then what they matched it against was age-adjusted breast cancer death rate per 100,000. So you can see here Thailand has a low total dietary fat intake and a low breast cancer death rate. Whereas when you look up in the upper right hand corner of the figure, the Netherlands, Denmark, New Zealand, the United Kingdom, Canada, Switzerland, we're up there in the US, we have a higher total dietary fat intake and a higher age-adjusted breast cancer death rate per 100,000. Again, this is not individual data. You cannot make assumptions about cause and effect on this, and you cannot make decisions or apply this to individual data. So the last type of observational study we're going to talk about is case series. And this is where we follow individuals, cases, and it's a series of them. So usually more than a couple, 3 or more, maybe up to 10. It could be hundreds of case series. It's where we don't have a traditional exposure and outcome. It's not formalized as that. This is often the oldest study design, and I think used when we're trying to uncover or discover why something is happening. So when we thought about with the first cases where these opportunistic infections were occurring in young, healthy males was puzzling to clinicians. And it didn't make sense because the type of infections that they were presenting with were often found only in elderly or patients who had immunocompromised immune systems. And so when the case series brought together these characteristics to help determine, okay, a group of patients that look similarly, it helped uncover the disease HIV, which was suppressing the immune system and increasing their risk for the opportunistic infections. So some common characteristics for the case series, again, they don't have a comparison group. We're tracking subjects, right? They may have a known exposure, or we may look at their medical records for both the exposure and the outcome. We're just kind of following subjects, not in a non formalized way, oftentimes with exposure and outcome, but looking at them to kind of help uncover or discover differences in associations between potential variables. And really this helps us to decide maybe where we might want to develop studies to gain different types of evidence. So this kind of is oftentimes the oldest study to kind of help uncover or discover when there were challenges in medicine. So here's an example of a case series, and this is HIV transmissions from mom to baby during breastfeeding. So what they did is they had 104 women, and 2 of those women had twins, so that's how we wound up with 106 kids. But they had blood loss during birth and received, or during vaginal delivery or C-section, and received a transfusion and contracted HIV through that transfusion. And what they did is follow the 106 children and found out that 38 became infected with HIV. So going back to our lecture on deciphering statistics, you can figure out the risk of HIV infection in these children. But this is an example of a case series where we didn't really know whether transmission could occur during breastfeeding, and this certainly provided some evidence that it did happen. Again, no control group, so we can't talk about relative risk and whether it would have happened in other situations or other scenarios, but this is awful helpful information to help determine how to guide policy and what to do in terms of recommendations for breastfeeding during breastfeeding. We're going to begin part 3 of Overview of Study Designs by talking about the evidence hierarchy. And I present this graphic to you to show you that the ability to determine cause and effect is greater as we go up the pyramid. So systematic literature reviews, SLR, meta-analysis, experiments, randomized control, that experimental study designs, they give us the best level of evidence to determine cause and effect. But I don't want you to be misled that the value of that type of evidence is the best, because there is value in all of these types of studies, and that we must use them oftentimes together to help create a picture. We know that experimental study designs, randomized control trials, they may be fraught with a lack of ability to generalize. The patients that are included in those studies may not represent the typical patient you see in your practice, or the typical scenario, or they have extra visits to help ensure adherence, whereas that may not mimic what happens in the real world. So we need to really use the different types of studies and the different types of evidence we get to complete a picture. So again, I present this because I think in the old days we used to say, oh, systematic literature meta-analyses, RCTs were the best, and then kind of didn't really pay much attention to the other evidence. We now know that that's not true, that we need all of these levels of evidence to help us determine a story and to really practice evidence-based medicine. So in this last section, I have some summary tables that I'm hoping will help compartmentalize some of the characteristics of study designs and help. I know there's a lot that we went through, especially when you get to observational, and sometimes they especially if it's your first exposure, they might tend to meld with one another. So I've got some summary tables, and I also have a nice flow chart that I find extremely helpful to differentiate the type of study design. And I'm going to walk you through that, and we'll also post that on Blackboard. So again, just a review of the analytical study designs, experimental versus observational, and the 5 types of observational studies that we talked about. This kind of helps distinguish what the study's purpose is and then what the study design that could commonly be used or is commonly used, right? So we talked about prevalence, right? That's the bathtub. That's cross-sectional studies. In other words, at one point in time, we want to know how many people have the disease. When we think about incidence, we've got to start with people who don't have the disease. We've got to look at the cohort, right? They may be exposed and unexposed, but they do not have the disease. Same with experimental. So we don't want people with the outcome. We randomize them treatment A, treatment B, and see who gets the outcome. And so if there's a placebo group in the experimental arm of the RCT, that may help provide us with incidence. So again, 2 different study designs that could help us with incidence. Prevalence, we often think of cross-sectional. And then if we're looking at the effects of exposure, our experimental data, again, provides good evidence of cause and effect, but observational data or cohort and case control, again, is very helpful to look at the associations because we know the exposure preceded the outcome. So different types of evidence, different types of study designs that can help answer these questions. So here's another, again, compartmentalization of longitudinality versus cross-sectional, right? So are we looking at patients and following them exposure to outcome over time? And most of them we are, except for the cross-sectional, right? The cross-sectional study is the only one that is really not looking at patients longitudinally. Ecologic and case series may be longitudinal or cross-sectional depending on how they're designed. They have the option for both a case series. I don't know if I said case series on those. So again, those 2 may have either longitudinal or cross-sectional abilities, but this helps differentiate between exposure preceding outcome and the amount of time that we're following patients. So on these last few slides, we're going to post this on Blackboard as well, but this guide, I think, is a very helpful guide to ask questions to help you distinguish or identify the type of study design. So the first question is you ask the unit of analysis. Is it individuals or groups? And if it's not an individual, it's an ecologic study. That's what we talked about, the country data. If it is individual, the next question we look at is the time frame. Are we capturing the exposure and disease at the same time? Yes, cross-sectional. If we know that the exposure precedes disease, then we can go into the longitudinal type studies. So here, if you focus on the longitudinal studies, we want to know if we start with the disease or we start with the exposure. If we start with the disease or non-diseased, we're looking at case control. If we start with the exposed and unexposed prior to the development of their disease, then we could look at whether the design is randomizing patients to an intervention, right? So we have exposed, unexposed, but are we randomizing them to be exposed or unexposed? That could be a randomized controlled trial, the experimental. Or it could be that we're looking at the cohort studies. And again, if the investigator, the outcome and the exposure happened, then the outcome, but if they've all happened in the past prior to the investigator getting involved, that's a retrospective cohort. But if the investigator gets involved and we're following them in the future to find out what outcome happens, that is prospective. So this really flowchart kind of walks you through. There's a lot of additional types of characteristics of study design. So for example, there's single retrospective and double retrospective, and we're not going to get into the nuances of those in this course, but I just wanted you to have this completeness as you go on in the future years in your curriculum and maybe asked to help distinguish among these types of study designs. So another summary of study designs or differentiate is looking at the measure of association you can use. So relative risk we use for randomized controlled trial cohort studies. That is when we know exposure precedes the outcome for the randomized control and the cohort study. The odds ratio is what we can use for all of them. the randomized controlled, cohort, and case control studies. So again, important to differentiate, not on this slide, but also that we talked about earlier is cross-sectional could use an odds ratio as well. So again, odds ratio can be used in almost all of the study designs that we talked about. Relative risk is limited to the RCTs and the cohort studies. So lastly, to summarize the overview of study designs, we know that experimental studies expose, they intervene, they expose study subjects or randomize them to treatment, while observational studies follow those that are already exposed. There's randomized controlled trials, cohort, case control study designs, as well as pragmatic clinical trial. They ensure that the exposure precedes the outcome, whereas cross-sectional studies do not. The experimental study designs may offer a higher level of evidence for a cause and effect, but they also suffer or may suffer from limitations about the lack of ability to generalize to a more diverse population. And then lastly, the evidence obtained from both experimental and observational evidence has influenced clinical practice and regulatory decisions. And this concludes the three-part series of overview of study designs.